right, what's up, my nurse peeps? It is Nurse Zach coming at you. We're going to be talking a little bit about hemodynamics. So first things first, we're going to be talking about stroke volume, preload, afterload, contractility, ejection fraction, cardiac output, and influencing factors that influence that whole shebang. So first and foremost, we're going to be talking about stroke volume. Stroke volume is the amount of blood ejected with each heartbeat. And so stroke volume, I mean, it's pretty simple. Your heart, the love dub, your ventricle squeeze, and the stroke volume is with one squeeze, how much blood comes out of your left ventricle into your aorta and the rest of your system. On average, it's between 60 mLs and 130 mLs, okay? And then over the course of a minute, it's between 4 liters to 6 liters. Preload. Preload is the degree of stretch of a cardiac muscle at the end of diastole. So you have the ventricles, they are filling in diastole, so the atrium is squeezing, blood into the ventricles, and your ventricles are stretching. And so it's the degree of stretch to which your cardiac muscles in the ventricles are allowing for the filling of the blood. Administration of IV fluids is obviously going to increase the amount of stretch, because if you're hypovolemic, it's not going to stretch that much because there's not that much fluid in your system. But if we go ahead and add fluid into your system, it stretches out more. So vasoconstriction. So if your system is, your whole system is more so squeezing blood out of your system, more blood is going to return to your superior vena cava and then your inferior vena cava, which is going to fill into your atrium, which is going to obviously fill back into your ventricles in the grand scheme of things. So those are two ways that you can increase the preload. Also ways that you can decrease the preload, because sometimes you don't want so much fluid in the system. Diuretics can actually take out the preload, or the amount of stretch on the heart. And then nitro, which is essentially the opposite effect of a vasoconstrictor. It's a vasodilator, so that means there's more fluid in the system, less in the heart. If there's less in the heart, there's less stretch. And then afterload. So preload, you're kind of looking at the before, where's the fluid coming from. Afterload is like, you're kind of looking, where's the fluid going. So if you're looking at your left ventricle, afterload is the resistance to ejection from the blood vessels. So if you're looking at your left ventricle, you're going to be looking at your systemic vascular resistance, your SVR. And so that is all of the pressure from essentially all of your arteries pushing back into your aorta. All that back pressure is your systemic vascular resistance. On the right side of the heart, because now the right side of the heart's not pumping to your whole system, the right side of the heart's pumping to your pulmonary part of your system. So it's the pulmonary vascular resistance, to the PVR. And so both of those things contribute essentially to the afterload. That's the resistance, the pushback of your system onto your left and or right ventricle. So things that will increase or things that will decrease the vascular resistance is vasodilation. And so anything that, like nitro or something, will open up the vessels of the heart. And so if the vessels, or open up the vessels of the body, if the vessels of the body are open, there's less pressure, there's less back pressure on the heart. And so with less back pressure of the heart, there's less afterload. Okay, so, and then there's things that will increase the afterload. So there's a couple things that will increase the afterload. It's vasoconstriction, so the opposite of vasodilation, obviously, vasoconstriction. So if the vessels in your body, in your system, are more constricted, when your ventricle goes to squeeze the blood out of the ventricle into your aortic system, if the vessels here are more constricted, then it's going to be more difficult. The afterload's going to be higher. And then also aortic stenosis. So your aorta it's a tube made out of tissue that can withstand, it's like highly pressurized tissue, okay? And so, but what happens over time, or what can happen over time, is that tissue can become stenosed or more rigid. And so instead of it having that give that accepts that amount of pressure from the heart, so that it stretches a little bit to withstand that, that stretch and that pliability of the aorta lessens over time. And so if it lessens over time and your left ventricle squeezing, like shooting this blood out, and you have your aorta here, that's not, as pliable as it used to be, because it's stenosed. That back pressure is going to be a lot higher because the aorta is not accepting the pressure. And so that back pressure is going to be higher on the left ventricle. And so that afterload is going to be higher. Contractility. So we talked about a little bit of the pressure, coming from the systemic system, and then also the pressure coming, from, or the pressure going forward, the pressure going back. But now just talking about the pressure of the heart itself. So the contractility of the heart is basically the strength of the heart. And how do you measure the strength of any contraction is the amount that these cardiac muscles can shrink. And so the cardiac muscles, if they can shorten in response to the electrical impulse, that contractility is higher. And so if the contractility is higher, that's going to improve the stroke volume. And so that increases with catecholamines, systemic nervous system, and then obviously with some medications. So like, epinephrine or something like that, get that contractility, gets it ready to go. It decreases with hypoxemia, acidosis, and then some other medications as well. The ejection fraction. So it's the ejection fraction is the percent of end diastolic volume. So that's the amount of blood that's left over in the heart after diastole. How much of that blood is pumped out from the ventricle into the remainder of the system. And so that is how much of it. So 100% of the blood in your ventricle is not pumped out every single time that your heart pumps. Like your heart doesn't pump itself dry or pump itself to the point where there's no blood in it and then it fills afterwards. So there's always going to be a little bit of blood left over. All right, and then so left ventricular ejection fraction, which is what they measure. You're not going to see too much like the right ventricle, but the left ventricle. Anything over 55% is normal. So it's a good ejection fraction. So a little bit more than half the blood at the end of diastole. So your heart relaxes, puts blood into the left ventricle. After that squeeze, more than half of the blood should go into the aorta. If there's less than half the blood, that's not a good ejection fraction. Influencing factors. So the autonomic nervous system. Baroreceptors, and baroreceptors are nerve cells that are through your cardiac system that are like in the lining of your aorta and in different parts of your body that measure the pressure. They're like kind of like pressure regulators to see, hey, like, is this the right amount of pressure that's going forth, being pumped in, because usually we feel more, usually we feel less, and so those things regulate. So if the baroreceptors send a signal back saying that the pressure's not high enough. So let's just say because your body's going to try and maintain your cardiac output. All right. So cardiac output is the stroke volume. So the amount of blood pumped out by every heartbeat, and then your heart rate. And so your heart rate times your stroke volume equals the amount of blood pumped in liters per minute. What affects that is obviously going to be the heart rate. And so baroreceptors are sensitive to changes in blood pressure. When you are hypotensive, the baroreceptors, realize, oh my goodness, this person is hypotensive. We have to increase the heart rate to maintain the cardiac output because the stroke volume is slacking. And so, or at least the baroreceptors believe that the stroke volume is not doing all that great. So it'll compensate by increasing your heart rate. The stroke volume is affected by preload and afterload, which we already discussed. So that is hemodynamics for you. And that was NCLEX. So good luck on your guys' next test, and I will see you in the next video.